This is Dr. Shiv Sarin from New Delhi, and I have my co-chair for co-moderator for today, Professor Simon Strasser from Australia. We welcome on behalf of APASL to all our listeners and also to the two very eminent speakers. And first of them is Professor Graham Cooke, who probably needs no introduction in the field of viral hepatitis. He has, from UK, led the Stop HCV campaign and has also done many guidelines in that area. We have known him personally. Without any ado, I would like him to take a very important talk on reduction in the duration of treatment using DAA for hepatitis C. Welcome, Professor Graham Cooke, to APASL webinar session 2, number 5. Welcome.
Well, thank you very much, and thank you for the very kind invitation. We're going to use the pre-recorded talk, I think, so you'll notice some continuity area as the shirt changes, but the room stays the same.
Okay.
Well, thank you very much for the invitation to talk today, and it's a bit odd to be doing it from at home, but thank you for asking me along, and thank you also for the opportunity to talk about something other than COVID, which I haven't done for a while. So I'm going to talk about some aspects of short course therapy for chronic hepatitis C, and I'm going to do this in the context initially about the challenge for elimination of viral hepatitis, and I'll touch on some of the reasons that we think about short course therapy and how we might do that. And I'll show a little bit of data from a trial that we've just finished before we can have a discussion about how things go forward from here. So I don't need to remind this audience of the burden of viral hepatitis, and this graph shows the numbers of deaths globally, with each circle proportionate to the numbers of deaths in each region. And as we know, the region covered by APASL is one of the most heavily affected in the world. And here, deaths from hepatitis C are represented in red. And we know that the WHO has got ambitious goals for the elimination of viral hepatitis as a public health threat. And last year, we brought together a big group, including many members of APASL, to think through in more detail about what was going to be required to achieve these elimination goals. And one of the key things that came out of this was a focus on national level policies. And we could look at 20 countries that represent 80% of the disease burden in the world. And many of these, at least 10, are in Southeast Asia or Asia more widely. And clearly, any effort to achieve elimination goals is going to need to be successful in each of these countries to have an impact globally. And these are ambitious targets. So the mortality target is to reduce mortality by 10% by 2020 and 65% by 2030, with equally ambitious targets for reduction in new infections. And the key point here is that to get to these targets, modelling that we've done and other groups have done shows that you probably need to get at least 80% of your eligible population treated by 2030. And the relevance of short course therapy is in helping to achieve that target. So just to focus more on hepatitis C, why does short course therapy help? Well, it's really a balance, and there are pros and cons, but really we think about this because it's a potential means to improve access to treatment, and that's primarily through potential benefits of reduced costs, but also increased adherence, and we'll talk a little bit more about that. But we have to balance that off against what might be a more complex regime and potential risks of treatment failure and resistance and retreatment, and also potential loss to follow-up from systems in terms of patients remaining in care. So just to talk briefly about costs, I think as many people remember 5 years ago or so, drug costs when these new DAAs came out were extremely high, and that was a major limitation to access. Increasingly, we've seen competition between originators, and prices have fallen a lot in developed economies, but in different parts of the world in different ways, price still remains a barrier to access in some countries. In the UK, we did a study which was really a thought experiment, recognizing that most licensed durations of therapies will overtreat the great majority of patients compared to what they need. And so we asked the question, which if we gave 4 weeks or 6 weeks or 8 weeks of what should be a 12-week course of treatment and then retreated anyone who failed, what would be the most cost-effective strategy that we could deploy? And clearly that is affected by the price of drugs, and that's changed quite a lot. But when these drugs were first introduced and the prices was probably somewhere here, we can see that we can model these strategies, and the 8-week strategy in this kind of approach was most likely to be the most cost-effective compared to 6 weeks or 4 weeks. And that holds true even as prices fall. But one of the issues is that if you can make shorter course therapy more effective, then that can become a more cost-effective strategy. And with this model, we estimated those numbers. So for a 4-week cure rate, we would really need to get cure rates up to 65%, and a 6-week over 77% for this strategy to be cost-effective. But really, this is a thought experiment and not something that we're really proposing as a widespread strategy. And prices clearly have fallen very significantly in all parts of the world, and in low-income settings with the highest burden of disease, voluntary licenses, the work of WHO and MPP brought generic prices down. So whereas early on costs were probably the biggest driver to think about different strategies in short course therapy, they're less important now than other factors. And I think probably the more important factor now, and increasingly important, is adherence to therapy. And we believe, although the evidence is yet to be very strong, that adherence is going to be better for courses that are shorter, and that we think adherence tends to drop off later in treatment courses. And this becomes relevant as treatment scale up and access to treatment improves. So we can imagine for an individual country that we move from a phase of interferon-based therapy through a phase of limited access to DAA therapy, through to a more unrestricted DAA access for chronic infection, which is where we got to in the UK in about 2018, through to where we are now in terms of prioritizing treating harder to reach patients, in particular trying to treat those who may be transmitting, prevent new infection with a view to elimination. And so how you view short course therapy probably depends a little bit on where you are in your individual country in terms of tackling the epidemic. And there is this balance. So clearly simple strategies are important to scale things up and to move fast. And certainly early on in a response, that's the key. But as things evolve and the efforts move towards elimination and beyond, then a more precise treatment of individual patients becomes relatively more important as part of the mix. And just to illustrate with a typical clinical scenario from my own setting, this is a fairly typical patient where I work. A 30-year-old man comes into hospital, an active injecting drug user. He is homeless and he's hospitalized because he has pneumonia and happens to have abnormal liver function test detected. He's worked up and is found to have hepatitis C, probably not for the first time, it's been diagnosed before. And his workup is started, but he's likely to have a relatively short admission. So the questions arise, well, should we be starting treatment immediately? And if we do, how would this patient then be followed up in outpatients? And so if we rephrase those questions from a more clinical perspective, is there a combination I can give this patient for less than 6 weeks that would give a high chance of cure? And if I start a combination and this patient's unlikely to finish it, what is the risk to that individual? How likely are they to be cured? And if they're not, what's the risk of failure? And at the moment, the evidence base, which I'll touch on in a minute, is not very strong. And I think it's one of the areas highlighted by WHO in their guidance from 2018, that really we need better data on the predictive factors for selecting people for shorter courses of therapy. So what do we mean by short course therapy? Well, clearly we've seen a huge shortening in therapy over the last 15, 20 years, and in particular the last 5 years, with improving SVR rates across genotypes and shorter courses. Now, we would probably say there are 3 main combinations recommended by WHO at least. Other combinations are clearly available in individual countries. But the 3 main ones globally will be sofosbuvir, velpatasvir, sofosbuvir, declatosphere, and glecaprevir, pibrentasvir. So all these with approved durations of therapy in general for most populations, non-cirrhotic populations, of between 8 and 12 weeks. So to talk about shortened therapy, we at least need to be talking about therapy that's less than 8 weeks. And in the efforts to try and develop combination therapies which could be given for less than 8 weeks, it hasn't been possible to do that. So at the moment, we don't have a sort of universal licensed combination that can give a sufficiently high cure rate. And this is a table extracted from a very good review by Emmanuel et al. In 2017. And this is just bringing out the data from drugs which have been licensed in one form or another. looking at durations of 4 and 6 weeks. And you can see here that although combinations like sofosbuvir, velpatasvir, and voxilatprevir can achieve high cure rates, they haven't been quite high enough to be universally used for 6 weeks of duration. So how do we have shorter courses of therapy that can have high cure rates? And I think this is a helpful theoretical graph, really. So the gold line here represents a mathematical estimation of the relationship between the duration of therapy and the likelihood of cure. And we can see this kind of sigmoid relationship. And in red, we can model what might happen if a patient missed a proportion of doses, and it's essentially shifting that curve. And the question arises, does this reflect reality? So we looked in detail at all the data we could find from real-world studies on duration of therapy and cure rates. And what we did find was a relationship that really sort of was quite similar to those modeled relationships, with a flattening of the curve as you drop from 12 weeks to 8 weeks of standard therapy, but then an accelerating decline down to 4 weeks. And you can see the confidence intervals widening with a lack of data. And below 4 weeks, we don't have a lot of information. There are a few studies for patients who've inadvertently stopped therapy, and I'll talk about 1 or 2 others shortly. But we think that this data sort of supports the concept that we're looking at this sigmoidal shape of relationship. And we know, even in our own practice, that there are a few patients, even with a few days of therapy, I think the shortest we've seen is with 13 days, that patients can be cured. So it's reasonable to think that a small number of patients may be curable with very short courses of therapy indeed. So in general terms, we may have a relationship for a particular combination that looks like this, and sometimes if a patient has other individual factors like cirrhosis, that may get shifted one way. And what we're trying to do is find ways of shift this curve further to the left, where the 100% rate is reached at durations of under 8 weeks, and ideally 6 or 4 weeks. So what can we do to do that? And I think broadly we have strategies that look at selecting patients on baseline characteristics, or potentially on treatment strategies. If we look at this, then in terms of baseline characteristics that may be relevant, I won't go through all of these in detail, but I'll highlight 1 or 2 of these. But viral load and genotype at baseline may be helpful. Resistance, the presence of RAS, host genetics like IL-28, interferon lambda-4, fibrosis, and other demographic factors like age and sex may help select a patient group who could be cured with shorter course of therapy more reliably. Other strategies involve adding licensed drugs, and in particular, I'll talk about 3 of these additional DAAs, potentially pegylated interferon still and ribavirin, and potentially increasing doses, although there's relatively little literature on this, and I won't go into that in detail. And of course, in the interferon era, on-treatment strategies and response-guided therapy was an important part of care, which isn't really part of care with DAAs, but maybe more that could be done in that area. So acute infection is a particular scenario, and it's clear from a number of studies that it's possible to shorten therapy from either 12 weeks to 8 weeks, or 8 weeks to 6 weeks in the case of GPIB, and still achieve relatively high cure rates. And we're seeing some studies which have gone down to between 1/2 and 2/3 of the recommended durations of therapy, where it's still possible to achieve high cure rates, although quite a lot of difference, and relatively small studies to allow broader conclusions to be drawn. And in one study that's, I don't think yet published, but even going down to 4 weeks in an HIV-negative acute infection group, found very high cure rates. So acute infection seems to be something different about it. I don't think we fully understand what it is that's different, but there may be aspects of viral diversity or host immune response that allow a shortening of therapy without compromising too much the SVR rates. Chronic infection is obviously different. And there are examples of where we are using baseline characteristics already to try and select patients for shorter courses of therapy. Obviously, one of those that's had most interest has been viral load, and probably the most widely used criteria for shortening therapy is in the use of sofosbuvir and liposphere, shortening from 12 weeks to 8 weeks as a result of the data that came out of the ION3 study some time ago. Tom O'Brien and colleagues have looked at this and dissected it in some detail just to explain how these thresholds came, and often there's a threshold recommendation that viral load under 6 million means that patients would be more suitable for 8 weeks of therapy. But as you can see, perhaps here, and I'll show you in a moment, that threshold, of where that threshold sits, is not clear cut. And if we look at the relapse rates according to baseline viral load from the ION3 data, we don't see a very clear cutoff between one level or another, although you can see maybe that the 6 million international units per mil mark does demarcate slightly. But in reality, really what we're probably looking at is more of a gradient here. And we're just putting an arbitrary, well, not an arbitrary, but we're putting a dichotomous cutoff in there to try and help. One area where selection can be helpful is genotyping and subgenotyping. And I think studies with combinations looking in particular at shorter courses of therapy for genotype 1b have been successful. The Garnet study, for example, with Vicarax and others, and they have been part of practice, but not to the point where we're treating patients for less than 8 weeks. And if we want to look at less than 8 weeks and even down to 4 weeks, then probably the better data we have is from studies that have looked at adding additional drugs. One of the early studies, which will be known to members of the faculty here, was led by George Lau and others, was looking at the ultra rapid response in a small number of patients who were using a combination of selected baseline factors and then adding an additional drug, and looking at a subgroup of patients who respond very rapidly, able to identify a group of patients who with only 3 weeks of treatment were able to achieve 100% SVR rate. Now, these are very selected, so this is a group of Chinese, mostly women, low BMI, mostly treatment naive. And so this is not necessarily a generalizable strategy, but it does show how it's possible to identify subgroups that may respond quickly. And one of the interesting things coming out of this work and other studies like this, studies like Synergy and studies elsewhere, is that some of the models that we have that we use to try and understand the relationship between decline in viral load and outcome of treatment don't seem to be as robust as we think. We think there are a first phase and a second phase decline in viral load, which needs to get below a certain threshold for the immune system to allow clearance of the virus, and ideally even lower to allow complete eradication of the virus. But what we see in some of these studies doesn't accurately predict well enough based on these characteristics who will be cured. And there's some interesting work, which I won't go into in detail here, but it's worth looking up, from one of the modeling teams published in 2017, which suggests that perhaps if you factor in the proportion of virus that's actually infectious and the impact of treatment on that gives you a much better model of short course therapy and its likelihood of success. And this may be a way that we can understand better that who's going to be cured successfully with very short courses of therapy. So in terms of licensed drugs that we could add in to try and shorten therapy considerably, I think it's worth just mentioning some data on pegylated interferon. Now, clearly pegylated interferon is a drug that by and large we're trying to get rid of because of its toxicity and some other costs in some places. But when it's only used for a very short course of time, it does offer an intriguing possibility of giving much shorter courses of therapy. And this is a study published from a Danish group a couple of years ago, which I think is quite interesting. Relatively small numbers, some selection of patients, so generally non-cirrhotic patients with viral loads under 2 million, relatively young population. But you can see here, with only 4 weeks of sofosbuvir in the liposphere, adding ribavirin and pegylated interferon, it was possible to achieve 100% SVR12 with a per patient protocol and only slightly lower on an intention to treat basis. And I think this is a strategy that's certainly not going to be something that's scaled up and widely used, but it's worth evaluating further in settings where there may be a finite window for treatment and you want to try and get as high a cure rate as possible. And then obviously the other drug that's widely used that may be valuable is ribavirin, a generic nucleoside analog, which in the interferon era was added in to try and improve outcomes, but clearly has a toxicity profile, particularly with longer use, but may have a role in preventing the emergence of resistance when patients fail therapy. And I'll show you a bit of data related to that. And there are relatively few, if any, actually randomized controlled trials powered enough to address the question of the value of DAAs, ribavirin, in addition to DAAs in the current era. Again, looking at the real world data that we can, in blue you see without ribavirin and red with ribavirin, there is a suggestion that actually at shorter courses of therapy, sofosbuvir-based courses of therapy at 4 weeks, there may be a benefit to adding ribavirin. And there's a small ongoing randomized trial from the same Danish group adding ribavirin to 4 weeks of gLPIB, which suggests a modest but potentially useful increase in SVR rates. And we'll wait to see the full data of that study. So there's very limited evidence base at the moment for shortened course therapy. We know that certain individual factors may be associated with successful outcome. But there are relatively few randomized controlled trials. And I'll finish just with a little bit of data from a trial we did in the UK, looking at patients with mild disease, having a cutoff that's relatively high at 10 million copies, and randomizing patients, first of all, to different durations of the same therapy, either a fixed 8-week therapy or a much shorter variable ultra-short strategy, with a view that anyone who's cured then finished. There was a second randomization to ribavirin with and without, so a factorial randomization. And anybody who didn't get cured on first-line therapy was then retreated with sofosbuvir, ledipasvir, and ribavirin for 12 weeks, with the overall primary outcome being the cure rates according to each of those strategies. And it's a slightly different, so the duration of therapy was based on a continual scale based on the viral load at baseline, trying to reflect a little bit more the biological reality of what goes on in patients. And what we found was that cure rates for the fixed dose strategy were just over 90%, with the very short VUS ultra short strategy 1, which is only a mean of 32 days of therapy, cure rates in the region of 36%, so quite low and certainly not high enough to be generalizable, but a relatively small increase in 9 days with the second strategy doubled the SVR rate to 72%. And interestingly, all patients were cured with retreatment therapy. So overall, these strategies were all non-inferior. And if nothing else, I think this gives us confidence to do studies like this, where we can treat patients with short course therapy to understand who's cured and not compromise retreatment, even with something like Harvoni and ribavirin. Did ribavirin adding help? Well, the short answer is not very much. In the ultra short course, the addition of ribavirin did improve slightly the SVR rates, but not significantly. And this is something that probably we won't be pursuing. But interestingly, and I've just asked you to focus on the left-hand panel here, it was very clear that if you failed therapy with ribavirin, the chances of resistance emerging were very significantly lower. So here, patients who had ribavirin, there was a slightly increased proportion of those who failed therapy who had resistance mutations detected. But comparing the blue bars of those who didn't have ribavirin, this was very much higher in those who didn't have it. And toxicity wasn't a major problem. We saw some transient anemia, but really ribavirin was very well tolerated in this group. And it may be that in patients where we think treatment might not be successful with short course therapy, that the addition of ribavirin could be a helpful adjunct, if nothing else, to try and reduce any risk of successful retreatment. And finally, just one slide on response-guided therapy. Unusually in this study, we looked at day 3 and day 7 virological responses. And only about 5% of patients were undetectable at day 3. But all of these patients achieved SVR12. So it's possible that in certain confined circumstances, the very early responses to treatment could still be helpful in predicting those who are going to get SVR12 rates, for example, in hospitalized patients. And I think more work is justified trying to understand that. So I think where we are, it's very unlikely we're going to get new hepatitis C drugs coming along. There was one drug, RG101, that some people may remember, that looked like it might be able to get therapy down with a single DAA to 4 weeks. But unfortunately, for toxicity reasons, that's not been taken forward. So I think the strategies we have are going to have to involve combinations and strategies with the medications that exist. And I think, analogous to tuberculosis, we need strategies increasingly that have strong evidence base for patients who struggle to engage with healthcare in different settings in different parts of the world and different parts of the community. And this is going to need a lot more prospective studies to really understand those combinations and have confidence in the outcomes to be able to use them within programs. And for us, this has meant moving to a collaborative work in Asia, particularly in Ho Chi Minh City, with an excellent group there, and developing some strategic trials, not least because there's a high proportion of patients with genotype 6 for whom we have relatively little data. So I'm going to finish there. There's a huge number of people to acknowledge for all the work that's gone on, and I thank you for your attention, and I hope we can have a productive question and answer session. Thank you.
I have a few questions which have come up during the discussions, and one of them is Professor Simon Strasser. She has asked, who is our co-chair, that failure to achieve SVR has impacts in the real life settings. So how essential is it to confirm SVR, particularly if you are doing a short course therapy and in marginal candidates. So do you think after 4, 6 or 8 weeks, whatever, would you like to do an SVR? Dr. Cooke?
Yes, I don't know if you can see me, but I hope you can hear me.
Yes.
So I think someone has to switch my video on. Here we go. So if I understand the question, the question would be if you were just using an unstratified short course of therapy, would you want to obtain SVR? And I think,
yes.
I mean, I guess as a principle, you would always want to, but in the circumstances where you feel compelled to use unstratified and unsupervised treatment, obviously it's going to be quite hard to do that. And I'm not sure that we have, you know, it's difficult to sort of really measure the impact in those circumstances of not measuring SVR. I think.
So should we or should we not? Should we do an SVR or not when you are doing unsupervised short courses?
Yeah, so I think that's what I was saying. I think, you know, generally speaking, as a principle, we would want to, but I think as we move into more marginalised populations where by necessity we can't supervise and we can't can't engage as well as we would like, then we're going to end up in circumstances where we can't always do that. And I think, you know, understanding how much effort it's worth putting in to find those patients again is dependent on the local circumstances, probably. But obviously, you would want to try and confirm that wherever possible, because you'd want to try and re-engage and treat anybody, particularly if you think that that's a group that's more likely to be transmitting, I think.
I have a few questions myself. First is, which, in simple terms, strategy would you recommend for short treatment? Is it 6 weeks, 8 weeks, or 4 weeks?
So I think I was quite careful not to recommend, because I don't think we have enough evidence to do that in a sort of blanket way, and it depends very much on what you're trying to achieve. So I think if your question is an economic one from a systems perspective, and you've got a 12-week licensed duration of therapy, then it may be that an 8-week duration of therapy is a reasonable way to go, but I'm certainly not recommending that. And I think what I'm putting more emphasis on is how you address an individual patient and what sort of evidence base you need when you're starting to think about the individual patient who, when you're not overwhelmed with patients engaged with care. And many systems are still just getting through stable chronic hepatitis C, but in some systems, those patients have largely been treated and there's more focus on the individual patient.
The second question is, would you like to categorize your patient based on liver fibrosis? Let's say somebody has a liver stiffness of more than 10 or less than 10. Would you, in the beginning, say that, okay, he's likely to be F3 fibrosis, his LSM is 10. I would try or would not try a short course?
Yeah, so obviously in the absence of high quality data, expert opinion prevails, right? But I'll try and resist the temptation. So, I think we clearly understand that having fibrosis and more severe fibrosis is going to make it harder to be cured with short course therapy. So it's very hard to imagine that you would select a subgroup of patients for short course therapy in the presence of fibrosis. But if you put it the other way around, that would probably be a factor that you would want to take into account for a patient where you thought you maybe had a month's window for therapy and you were trying to assess the likelihood of cure, then that would be an important factor to put into the equation. But I think the key overarching point is that we still need a lot more bigger data sets with more variables in them to understand the interaction of all these variables in an individual patient. I mean, I think one of the points I was trying to get across was that we've done lots of work looking at individual variables, but not very much where we put a group of variables together prospectively.
So in patients who are likely to be having more fibrosis or advanced fibrosis or cirrhosis, I think we don't have enough data to say that a short course of therapy could be used, and preferably use it for less fibrosis patients.
So certainly if we're talking about short course below 8 weeks for sure, and if we're wanting to try and achieve very high SVR rates. I mean, I think if you think about the cirrhotic patients and some of the recommended regimes that we still have that are 24 weeks, then short course therapy takes on a different question. And so clearly there are potential to identify subgroups of cirrhotics who don't need those prolonged courses of therapy. And I think there are some studies going on including one we're doing in
For
Vietnam.
common people, to put them, all the, viewers, we have close to 280 or 60 viewers. To put in simple terms, we don't have, as of now, a clear guidelines to say for them. And my last question is to you is a retreatment strategy. Suppose you have given an 8-week or 6 weeks course, and he has a relapse. Now, would you treat him again with 8 weeks short course, or would you give him 12 weeks or 24 weeks?
Well, again, it depends very much on what the specific circumstances you're working in are. If you've chosen a short course therapy because you think the patient's going to struggle to adhere to therapy, then it won't make sense to go to a longer course of therapy for retreatment. And if the failure of a short course therapy was in part due to adherence, then maybe the same course would make sense, but it's unlikely that you would want to embark on the same strategy twice, potentially. I think there's a broader question about strategies for retreatment, because at the moment we don't really have very many retreatment combinations licensed, apart from Soft-Bell-Vox and one or two others. And obviously in many parts of the world, particularly in Asia, those treatments are relatively hard to access, and Soft-Bell-Vox is still not widely accessible. So, looking at that study that we did, we saw very high cure rates with some other treatments, Harvoni and Ribavirin, for example. I'm not recommending those, again, as something that would be routinely used, but there is interest from some organizations, including CHAI and others, in exploring the role of other agents as potential retreatment agents where access to things like...
So you recommend newer treatments rather than same regimen for longer duration?
So I missed the question, sorry.
I would suggest you would like a different regimen rather than extending the duration of the previous regimen. But yeah, I'll also, because of limited time, I'll ask you the question by Professor George Lau, who also had a Lancet gastrohepatology paper, a short course therapy, and which was probably one of the first. And George wants to know, do we have cost effectiveness based on generic pricing?
So if the question is, has that sort of work been done, like I showed you at the start, with generic pricing? I've not seen that, but the model does take those prices down to the range that would be available for generic pricing. So if we say first-line therapy might be $50 and retreatment might be, somewhere a bit higher than that, then you can look at those models. But I've not seen data looking at that. I know there are people in Pakistan, Saeed Hamid, for example, who are interested in this question, and it's a question we're looking at in Vietnam, again, in G6 population. So there may well be data there, but I'm not sure I've seen it, if it is.
Would like to thank you, Professor Cooke, for joining us, and also to say and give us, I think there are many comments which say, excellent, superb lecture. So just want to compliment you for the time you've taken and given on a Saturday. And to our viewers, I would now just give two things. One, the APASL study, that is the Asian Pacific COVID study, the liver injury spectrum study, has gone online probably today. And so APASL 1 is on, and we request you to join for APASL 2. And with that, I would like to hand over to our co-moderator, Professor Simon Strasser, for the second talk. Simon, it's your time.
Thank you, Shiv. It's my very great pleasure to welcome a giant of international hepatology to give us our next talk, moving from hepatitis C to hepatitis B for the next discussion. Professor Massimo Colombo is Director of the Center for Translational Research in Liver Disease at Humanitas Research Hospital in Rossano, Italy. In the past 15 years, he's been Chairman of the Division of Gastroenterology and Hepatology and Chairman of the Department of Medicine and Liver, Kidney, Lung, Bone Marrow and Organ Transplantation at the IRCCS Maggiore Hospital in Milan, in Italy. And he is very, very well acclaimed, as many people know. He's got particular research interests in the diagnosis and treatment of viral hepatitis and in liver cancer, and is a member of many professional societies and received many, many awards. He's also been editor and editor-in-chief of many journals, and has an amazing CV with an age index of 91 and more than 27,000 citations. So I'd very much like to welcome Professor Colombo to the APASL Hepatology webinar series to give us his talk on risk models for HCC in chronic hepatitis B. Welcome, Massimo.
Thank you so much, Simon. Very kind of you for the nice words. I'm very happy to be here with you, and I understand that now the pre-recorded presentation is going to be delivered by your side. Thank you so much.
Thank you.
Okay, good afternoon. First of all, I wish to thank APASL for this invitation. My task today is to discuss the risk models for hepatocellular carcinoma in chronic hepatitis B. These are my conflict of interest. And I wish to start to tell you that the analysis of the personalized assessment of the individual risk of liver cancer in chronic hepatitis C patients must be regarded in the context of our efforts of improving early diagnosis and treatment of patients with liver cancer related to chronic infection with hepatitis B. So I will briefly discuss the why and the how. Why personalized assessment of the individual risk? Because surveillance programs, as well as antiviral therapy of hepatitis B, may not be cost-effective in certain subgroups of patients, exactly those who have a low annual incidence of liver cancer. And currently, in this COVID era, to prioritize patients with liver cancer screening at a time of limited resources and the concern of a potential nosocomial transmission and strict social distances. On the top of this, we wish to ask ourselves, how can we achieve such a goal, owing to the fact that the liver cancer follows a multi-step pathway. A single parameter on its own could not provide a robust predictive performance. In the very beginning, we identify cirrhosis first as a predictor of liver cancer and subsequently serum levels of DNA, but they are not enough. Conventional risk scores that are now in place are built on a varying combination of host and disease factors. And let me tell you that to construct a risk for liver cancer, we need to scrutinize through univariable and multivariable analysis the cohort of patients who have been chronically infected with hepatitis B while receiving or not receiving antiviral therapy. And this was aimed to identify independent risk factors and, most importantly, their corresponding weights. Not all factors weigh the same. A risk score is therefore constructed in a training cohort, and the accuracy of such a score becomes frequently validated in another independent cohort of patients, the so-called validation cohort. Based on this course, patients with chronic hepatitis B are now stratified in subgroups of low, intermediate, and high risk for liver cancer. And currently, we dispose of at least 12 different risk scores in untreated patients, all from East Asia. And I must say that at least in the West, we no longer see patients that are left untreated after diagnosis of chronic hepatitis B, provided they fit the criteria to start therapy. They must have a certain level of viral replication along with a certain degree of liver impairment. Currently, there are 7 different risk scores that have been generated in nucleotide treated patients. 6 were from Eastern Asia, 1 from the Caucasians world, mainly Europe. Wishing to briefly analyze the evolving concepts behind the design of risk stratification score for liver cancer in patients with chronic hepatitis B, it should be said at the very beginning, the start was in 2003, when the American Association for the Study of the Liver delivered the general guidelines for treatment of liver cancer, where it was said that screening of carriers of hepatitis B with at least 0.2% annual risk of developing cancer, and a screening of patients with cirrhosis due to hepatitis B with at least 1.5% risk of developing cancer at a yearly basis were cost effective. We rapidly moved to the construction of the risk scores to stratify categories of patients with chronic hepatitis B, incorporating basically the two main important parameters that were predictor of liver cancer: advanced liver disease and serum levels of hepatitis B virus DNA, you might see here. And the very first one was in 2009, China, the GAG-HCC, followed by other 3 scores, the most popular ones. And here you can appreciate that these scores were generated by combining certain characteristics of virus on the host. The very first one, GAG, included also the core promoter mutation of the hepatitis B virus that proved to be not user-friendly and was soon abandoned, to be replaced by user-friendly tests that were routinely performed in patients with chronic hepatitis B. What is the general message of these studies? The general message is that the negative predictive factor, the ability to rule out the risk of developing cancer, let's say in 5 years' time of follow-up, was excellent, superb, around 98%. This was also the same for the scores that have been developed later on in the population of patients that had been treated with effective antiviral therapy and were therefore chronically suppressed for their hepatitis B infection. This score was a little bit easier because the one generated in the Caucasian world, the so-called PAGE, was just created combining platelets, which is a strong predictor of liver disease severity, age, which is a strong predictor of cancer and duration of infection, and gender, which is a strong predictor of liver cancer because men are more prone to develop cancer than women. In a modified version, albumin was added thereafter. But the first score to be generated to investigate the treated patient was the modified REACH-B, that was generated from the REVEAL cohort in Taiwan. You know, REVEAL cohort was the one that first identified serum levels of DNA to be predictive of liver cancer, and subsequently there was a strengthening by the addition of other parameters to generate an homogram that included also quantitative HBsAg. But to be clear, what was a real breakthrough in these very last scores was the introduction of the assessment of liver stiffness as a parameter predictive of cirrhosis and advanced liver disease. And as you see here, the negative predictive value of this score was superb, at variance with the positive predictive values, which was quite low, ranging from 8 to 21%, telling you that using these scores in untreated and treated patients, we are able to identify persons that for 5 years could skip screening safely, because if those patients meet the criteria for skipping screening, i.e. having optimal cutoff values for low risk, which in each of these scores is different, then this patient can be safely followed up clinically without the need of a screening. On the other way around, if you wish to identify patients at higher risk of developing cancer, even using optimal cutoffs for this increased risk, you might fail to identify the right population in 8 cases out of 10. So the general message is risk stratification score are optimal to relax screening, are poor to identify the best person to screen for the risk of liver cancer. Here is a review article that has been recently published by Dr. Zhang, and also a comment coming from a review article written by Professor Papatheodoridis in Athens that dealt with the validation of the risk stratification scores for liver cancer in treated patients with chronic hepatitis B. There are at least 7 studies in which tests were validated in independent cohort, and again, you see here, excellent negative predictive value for this score. Whereas when studies were done comparing different different risk score models in the same population, the general information is that the modified RICH-B, which is here, will perform very well compared to the conventional risk score in the Asian cohorts of treated population, whereas page B performed very well and was also superior to certain conventional risk score in the Caucasian population, and the modified page B was excellent also in the Asian cohorts. You see here, this is an important study done in Korea, South Korea, where the modified RICH-B appeared to be superior to the rest of the Chinese university score, the GAS score, and the stiffness HCC score, and the RICH-B score in a population of treated patients. So in the era of antiviral therapy, this combined analysis was rather convincing for abandoning serum DNA level assessment, whereas the incorporation of a test able to pick up the fibrotic burden of the liver proved to be of strategic importance. And this work at 3 years and the 5 years follow-up. Along this line, we in the Western world are very confident that our very simplified scheme of analysis, page B predictor, is able to stratify patients for the risk of liver cancer. And if we apply the modified page B, we are able to see exactly the same benefits in the Asian population. This has been recently published by Professor Heap in the Journal of Hepatology, and is notable here that in both page B and in the modified page B, the negative predictive value for the low risk population, those with less than 10 in terms of point, is almost absolute. But there is an additional information coming from the utilization of the page B score, and is the dynamics of this score of these models over the years. If you focus on this paper that is published in Hepatology by Professor Georgios Papatheodoridis and Professor Pietro Lamperticon from our group in Milano, you might say what? That in chronic hepatitis B patients, there is no substantial difference in the rate of decline of the HCC risk over a period of 10 years of effective antiviral suppression. If you switch to the compensate cirrhotic, which is the best of our population in terms of risk of developing liver cancer, what you notice here is that the early incidence of HCC start declining after 5 years of continuous therapy with the nucleoside or nucleotide analogs, to tell you that there is a significant decline after year 5 of suppressive therapy. So the message here are twofold. One, you have to wait 5 years before appreciating a substantial decline in the risk of liver cancer in patients that are scrutinized with the page B score. And message number 2, after 5 years of therapy with NAs, you need to apply additional tests to identify those who remain at significant risk of developing liver cancer. And this is in fact what they did recently. These 2 authors published in the Journal of Hepatology, this nice paper, where they developed 2 special, let's say, subtypes of the page B score. In the qHBsAg score, where patients were categorized according to the age and the outcomes of the stiffness or transient elastography assay, there is evidence that if the qH score is between 0 and 5, patients with significant liver disease or were under nucleotide or nucleoside suppression for 12 years have remained free of liver cancer risk. And the same is true if you use the other score system called SAGE-B, where there is a combination of age plus 2 only a dichotomy in the transient elastography assay, and you see again that there is a population of patients with low score between 0 and 5 that have null risk of developing cancer over 12 years. Of course, these data should be taken cautiously because these have been generated in the multi-center study, so there are heterogeneity in the sensitivity of the working activities in those centers, and there is also perhaps a different impact of ethnicity in the various parts of Europe. And of course, in terms of translational medicine, these new scores have not been validated in populations other than the Caucasians. At that point, with this, let's say, short analysis of the state of the art, we can better understand how the liver societies have incorporated the risk stratification score in their recommendations algorithm for surveillance of patients with chronic hepatitis B. No question that all societies tell us that the presence of cirrhosis mandates surveillance. Second, all societies mandate screening with abdominal ultrasound every 6 months. The European Society (EASL), however, tell us to stratify patients according to page B. So page B intermediate and page B with high risk are those that are required to be screened. The American Society tell us that the non-cirrhotic patients with hepatitis B should undergo screening according to different criteria. So they do not take care of the scores, predictive score that we have discussed, but they tell us that patients with active hepatitis, elevated transaminase or high viral load, a family history of cancer, the ethnics, African or African Americans, or the Asian males over 40 and the Asian females over 50 years is the target of a screening program that again should be carried out with semi-annual intervals of abdominal ultrasound examination. The APASL words instead focus simply on these criteria. Asian females more than 50, Asian males more than 40, African less than 20. Africans is obvious. They are exposed to infections early in life and develop cancer earlier. In some instances with the help also of environmental factors such as aflatoxin, and those who have a genetic predisposition that can be roughly identified in a family history. Now, the obvious question that comes is how clinically useful are the HCC high score? Is there any doubtful position in using them? What are the warnings, the caveats? Okay. Point one, the existing scores do not cover some ethnicities and race. We said that, African above all, and African is a big reservoir of liver cancer. And these people usually develop cancer early in life. So we need to test this risk score in this population. Second, these scores hardly apply to patients in the e antigen positive, once defined as immunotolerant phase. And the same is true for those patients who are e antigen negative but have a chronic infection, not chronic hepatitis. And in that phase, this patient may still have some fluctuation of their disease because they might be erroneously, misleadingly classified as inactive cardiac, but they might have, in fact, a chronic infection that here and there might develop with some flares of liver disease. So this score should be dynamically assessed in this population. Point three, scores have not been validated in untreated Caucasians, and the reason is simple. Here in the West, in the most countries, patients are not deferred to therapy if they fit the criteria of treatment, and this is even more so since the generics have become available in the eastern part of Europe. So in the West, most treatment-eligible patients are being recruited to antiviral therapy at the time of diagnosis and are therefore not eligible to follow-up studies as an untreated population. Point 4, re-stratification of treated cirrhotics remains challenging. HCC risk declines after 5 years of therapy, but it remains above the cost-effectiveness threshold for surveillance, which, as you know, is 1.6, 1.5% per year. So these are the remaining uncertainties. This fosters our attention to see whether there are potential interventions to increase the effectiveness of liver cancer surveillance in patients with chronic hepatitis B, starting from stratification of patients for their risk. The first approach could be incorporating new biomarkers of hepatitis B infection, and two above all, quantitative HBs antigen and the hepatitis B core antigen, core-related antigen. These have been selected through a pragmatical approach among the many viral biomarkers that are available that qualify and increase risk of liver cancer. And of course, there are also a number of host biomarkers from the genetic domain, apart from the clinical inflammatory biomarkers, that could be utilized for this purpose. But everyone believes that HCC score should be user-friendly. So they should incorporate tests that are routinely performed in the clinics. And sooner or later, almost everyone, good hepatologist, will be using quantitative DNA and hepatitis B core related antigen to monitor the disease evolution in their patients. This is a study that's been recently published last year by Professor Zheng, but Professor Zheng was a pioneer because he published in gastroenterology in 2012 the first study telling us that quantitative HBs antigen in e-antigen negative patients with low viremia was very informative about the risk of developing liver cancer. And he struggled to develop a kind of a cutoff that was clinically useful. Such a cutoff was basically 1,000 international units. In this, let's say, follow-up study, again, on a large set of Taiwanese patients, because Taiwan was pioneer in the study, as you know, of the relationship between viremia and the risk of progressive liver disease, cirrhosis, and cancer. The Professor Zheng added on to his previous investigation, telling us that if you can stratify your patients according to the hepatitis core-related antigen, particularly in the set of those with intermediate viremia, let's say those with between 2,000 and 20,000, then you can identify those who are more prone to develop cancer. So in summary, this slide, encompasses what has been done in the last 10 years in the domain of quantitative HBs antigen and quantitative hepatitis B core antigen. Both assays are, biologically speaking, relevant. HBs antigen, as you know, can be the product of the translational activity of cccDNA and also of integrated DNA. So it's not perfectly aligned with the risk of liver cancer that is driven by cccDNA. But the core antigen is more aligned to the risk of liver cancer because it is more aligned to the translational activity of cccDNA. So the information here is that if you use the cutoff of 1,000 HBs antigen in the low viremic patient, you can identify those who are more prone to develop every year liver cancer. And this is even more so in patients, we have intermediate viremia. And in the patients with intermediate viremia, having more than 10 kilounits of Hep B correlated antigen, identify those patients who are more likely to develop cancer compared to those who have less than 10. So this might be really impactful. The second approach could be tailoring screening interval according to the level of HCC risk. This is a very challenging issue. Why? Because we perfectly know that the risk of developing cancer that is related to multiple factors, from genetic to the virus and the host risk modifiers variables, does not parallel the growth speed of the tumor. So interval screening have been decided on the basis of the ideal time frame that picks up as many as possible tumor at the very small burden. And this study is to answer the question, should surveillance be relaxed in patients at low risk of HCC? If you look at these studies that we have discussed and have been reviewed by Dr. Volgaris and Papa Theodoridis on Liver International March this year, GAG, HC, CU, HCC, RHB, REACH modified, LSM, meaning transit elastography HCC, PHB, modified HBB, it is quite clear that we have a tool to identify in 98–95% of the cases those patients who can safely stay 5 years without doing any screening. But what is really important is, can we really exclude cirrhosis in all of these patients, and cirrhosis remain a mainstay, a priority in screening? And most importantly, we have gathered information that certain covariates like metabolic syndrome may foster the risk of liver cancer in chronic hepatitis B. So should we mind of those comorbidities that may affect the liver? Diabetes, obesity, alcohol abuse, that are not incorporated in this screening. And the second point is the other way around. Should we enhance surveillance in patients at higher risk of HCC? And the answer is actually no. The Liver Society replied no. First of all, because we are largely imperfect and suboptimal in the identification of these patients. The second, because, as we said, the risk of developing cancer does not parallel the growth speed of the tumor. If you look at this recent meta-analysis published on GUT by the group of Amit Singhal, 20 studies, 1,300 cases of cancer from the West and from the East, on average, the pool time volume doubling, tumor volume doubling time of liver cancer is 4.6 months, with a range 3.9 and 5.3. But there is a but, that 1/3 of those cases were moving rapidly. 1/3 was intermediate, and 1/3 was sleeping tumors. And when subgroup analysis was carried out, it is true, Asia reported shorter doubling times compared to the West. And even more so, rapid tumor growth was concentrated in hepatitis B virus. But as we said, it is not scientifically acceptable that enhancing the interval of screening might identify tumors in a cost-effective manner, because in the end, if you enhance the interval of screening, you have to deal with a number of small lesions that are not amenable to be classified as liver cancer using non-invasive methodologies like MRI, or invasive methodologies like echo-guided thin liver biopsies. So, no surprise that all societies, the American, the European, the Asian Pacific, the Latin, and the National Cancer in America Society recommend ultrasound every 6 months. An open question is whether this should be accompanied by alpha-fetoprotein, and whether it should be done with alternative imaging modalities. This is another meta-analysis by the group of Amit Singhal that tells you something important that all of you know. There is a large heterogeneity in the sensitivity of cancer detection through abdominal ultrasound, going from the West to the East. And here the Italians are very well represented. You know, Bologna in Bologna, Sant'Agostino San Giovanni in my place in Milano, and Erion Tradati Milano again, Pateron Erion in France, plus the East. But the crucial point in my personal opinion, of course, is that if you look at this meta-analysis, you realize that the ability of ultrasound to detect early cancer is overall at the best 45% and raises to 62% with this accompanied with alpha-fetoprotein. So rather than insisting in stratifying patients with chronic hepatitis B, we should look at better modalities to identify small cancer. And these better modalities could be, like this slide tells you, alternating tests that are more sensitive, like computed tomography. And this has been done in this study, where the alternating computed tomography with ultrasound led to 2.5 rate of diagnostic sensitivity compared to ultrasound, or in this prospective cohort using MRI. And you see here that MRI led to 86% detection of cancer compared to 28% of ultrasound. More recently, a nice study published in Korea, Journal of Hepatology this year, told us that we can also use non-enhanced MRI. So for cost effectiveness reasons, to reduce time of analysis and to reduce the cost, non-enhanced MRI might lead to an increased detection of small tumors. Here we are dealing with, detection of small tumors, 79.1% sensitivity with MRI versus echography, ultrasounds, with a very high specificity, 98%, with a positive predictive value, which is outstanding, 72%, and the negative predictive values, which is almost absolute. So, Mr. Chairperson, let me finish my presentation with this cartoon that I derived from a nice paper of a big expert in screening, Amit Sindal, recently published in Journal of Hepatology. What we can do to increase effectiveness of surveillance, which is currently recommended at semi-annual ultrasound intervals. We could work trying to increase the surveillance rates. We should promote education, patients' education, practitioner training, and trying to have the primary care physician involved in this. In Italy, most of the surveillance is run at the hospital levels, and there is a little activity in the community. We might try improving compliance, so with this system-level intervention, dedicated clinical pathways, clinical reminder systems, navigate on progress, and made outreach that proved to be very effective, mailing to patients. The other approach is to refine the screening strategies. As we said, improving risk stratification, so optimizing the currently available prediction markers, perhaps using artificial intelligence, machine learning. At that point, we might have a patient distributed into pockets. One pocket are the low hepatocellular carcinoma risks that go to the semi-annual, and the other moderate and high HCC risk, where they could be approached with a screening, more aggressive screening, but this time using MRI or CT scan, not ultrasound, because otherwise, in terms of cost effectiveness, we fail the purpose. Of course, in conjunction with the early diagnosis biomarkers that need desperately to be developed. And with this, I'm finished, and I thank you very much for your attention.
Thank you so much for that wonderful lecture, Massimo. We are running a little over, but we will take some questions that have come through on the chat over the next 5 minutes, if you're happy to address those, Massimo. One of the questions has come from Professor Lau, who's concerned about the fact that we're really just talking about incident HCC, yes or no, and how does staging fit into this? What do we know about the actual staging of the cancers in terms of, say, BCLCs Are they all A's and zeros, or are there some B's and C's? Do we have data on that at the time of diagnosis? And how do the predictive scores relate to actual outcomes rather than just incidence? Are you there, Professor Colombo?
If I understood correctly, the question is whether applying this score stratifying screening, we end up with easy to treat cancer or not?
Yeah.
Was that the question?
And
well,
how it relates to outcomes, not just incidence.
Yeah, I fully agree with the comment by George Lau. Screening must be weighted on the basis of a reduced mortality in the cohort population, and this is not still available. I think that most of these studies focus on our ability to identify patients at risk, not at risk of surviving after the operation. So this, I believe this is the next step we need to pursue.
Also, another question. On your last slide, you talk about strategies to improve outcomes of HCC and improve surveillance, including moving more to primary care. And certainly in Australia, that's what we've done. So a lot of hepatitis B care is now in the primary care setting. How much do we risk overcomplicating things if we move away from the current guidelines of really what is age-based and cirrhosis or no cirrhosis-based surveillance strategies, and move to more complex ones where we are surveilling some patients but not other patients?
Yeah, thank you for your question. I think that one of the reason for the success of PHB is that it's this very simple score where the risk of advanced liver disease, basically cirrhosis, is compounded by the presence of platelets and age of the patients that are good predictors of disease severity. And I think that they fit the purpose of running screening in the primary care domain. What is really important, at least in Italy, is that we still miss screening for liver disease in the general population. So we are, running short of targets, of the right targets. So we are failing to identify the right target for screening because we do not have a screening program going forward among the general population to identify patients with a chronic liver disease that deserve to be stratified for screening.
So I guess that also brings to one of the other questions that's come through the chat is around, and you did briefly mention, is around comorbidities in patients with hepatitis B, and particularly in the Asia Pacific. This is becoming an increasing issue and is not clearly covered in the risk scores and the other strategies that have been published. So the rising obesity and diabetes rates and the metabolic associated liver disease and the rising rates of alcohol-related liver disease are a real issue around the region. How do we, in practice now, incorporate that into what we know about these risk scores?
Yeah, this is an important question. There are at least 3 papers that clearly demonstrate an association between its increased risk of liver cancer during hepatitis B infections in treated population also, and the phenotype of metabolic syndrome, particularly steatosis. So I think that we should start incorporating steatosis as a risk factor of liver cancer, but this is risky because at least in our general population, overweight and steatosis are quite widespread, and also diagnosis of steatosis is cumbersome. If you depend on liver histology, which is not longer done, more than 5% of fatty liver cells implies steatosis. If you go by ultrasound, the diagnostic sensitivity cutoff is at the range of 25% of the fatty liver cells. So the real question is how you define steatosis on a clinical grounds.
Thank you.
I think diabetes, to be very pragmatic, diabetes should be taken care of because in most of the patients in the hepatitis C domain and the hepatitis B domain, after either eradication or chronic suppression, diabetes matters as a residual risk of liver cancer in this population.
Thank you. And I'll take just one last question, which is, you pointed out the current APASL guidelines for HCC surveillance in chronic hepatitis B being Asian females over 50, Asian males over 40, obviously Africans and those with a family history and all cirrhotics. Is it time that we change those guidelines in the Asia Pacific based on the data that you've shown this evening?
I don't want to interfere with your policies, but I think you should.
How would we change them?
Well, I tell you, I would remove the ethnicity. I would go more strictly to the risk score system, perhaps.
Thank you.
Switching.
Thank you very much for that wonderful talk and for answering our questions. I'd like to hand back to Professor Sarin to close this evening's webinar.
Thank you, Simon.
Yes.
It was good to meet you. Thank you.
It was a great pleasure, Massimo, and very educative for all of us. And there are many more questions I can see on the question answer in the chat box, but due to constraints in time, I would like to thank Professor Graham Cooke, as well as you and all the viewers and listeners, and of course my co-chair, an executive council member of the APASL, Professor Simon, for joining us. One more time to remind you, the COPLA-1 study, that is the APASL-1, has been published, and APASL-2 survey is going on. Please join us. That is on the guidelines, and I request both the UK and the EASL people also to join, like we join everyone else. With that, we thank you all, and we hope that the APASL webinar next week on Saturday would be as educative as ever. Thank you all.
Thank you, everyone.